We're going to do it without a pointer. This is my disclosure. I want to show you how you can use ultrasound to treat vascular occlusions, but we like to call it vascular adverse events. This is an old slide. We're now somewhere around 170 cases that we treated ultrasound guided. And you have to keep in mind that we're still looking at hypothesis. So the current hypothesis is an intravascular injection of filler in an artery or in a vein. We have thrombosis, compression of a vessel, and we like to add spasm as well. And it may be a combination of everything, but you have to keep in mind that the eye artery is an end artery. Your face, the arteries in your face, you can cut an artery, you can ligate an artery, you can on purpose embolize an artery to stop a bleeding. There is no problem. So even if it's an intra-arterial filler injection, there should be another component. And this is what we see on ultrasound. So I don't have a pointer, but you see the artery in the fascia or in the muscle. You see that coursing underneath in the image. And then you see halfway a perforator piercing through. And this is well known in plastic surgery. You have your perforasomes or your angiosomes, and they supply blood. Oh, thank you so much. They supply blood for a certain area of skin and superficial fat. The artery moves on, another perforator, and they're good neighbors. They are connected. So you have two levels by which the artery have anastomosis, and they can help each other if that would be necessary. So this is how it will look on ultrasound. You have the fascia, your artery coursing in the fascia, superficial fat, and on top you have your skin layers. And here you see the perforator piercing through artery microvascularization. This is what a normal skin will look like. But of course, we also have abnormal skin with problems after filler treatments. This is the nasal bone, this is the cartilage, and we have two propositions. So if you see a round structure here, this is the middle of the nose, where the filler was injected, but the necrosis is not over there. Then we have another proposition, and that is where the area lateral on the nose, where you have the necrosis. So I put a color box on, and here you have the filler. This is on the middle of the nose. You see a lot of hypervascularity. This is the marbling pattern of the nose. I go down underneath the necrosis, no microvascularization. You see the difference? So I slowly move upwards. Here, nothing to see. I slowly move upwards to the middle of the nose. No necrosis, but a lot of good neighbors trying to help that area where we have no flow. Hypervascularity, slowly move down. So this is the area underneath the necrosis where we're lacking blood flow. This is not where your filler is. So we're going to inject hyaluronidase, which will help the capillary refunction. 27 long needle. We do not do any anesthesia because I want to know if the pain and the complaints are gone after treatment. We're injecting where we expect the perforators. We're injecting here on the border, and there's your perforator, 75 units of hyaluronidase. And this is very disappointing because the nose hardly has any flow. So this is what you see. You see a little bit of perforators coming back. There you are. This is all you need to see. At the same time, the complaints and the pain and the pressure of the patients are gone or they're halfway. And now if we see this patient back after 3 days, this is how she looks like. So again, we're going to look with ultrasound. The HA is still there. This is the middle of the nose with that round structure. Still some hypervascularity, but almost everything is gone because there is no need to help the neighbors, because the neighbors are perfectly fine now. So this is the area that we treated with the blue artery. We have good flow back. Here again, hypervascularity is almost gone. The only thing we did was hyaluronidase, 75 units, and you can follow up with ultrasound, you can do your management, you can find the area that you need to inject. And what we found treating all these cases, so again, here you can see flow is back in the microvascularization perforator, microvascularization, here we have the tip of the nose, and then after 1 week she is healed, but we have to wait a little bit for that. So this is all we do. Here we are, 3 days, 1 week. So why is this important? Perforator, all the areas that are supplied by this perforator, another perforator, and here you see that you have the linking anastomosis. And what we see is that arteries are very unpredictable, perforators are very predictable. And this may help you, because what we noticed in all the cases that we treated is that all the marbling patterns are the same. Every lower lip has the same triangle. Oh, this one. And if you look in body donors, you can see that little triangle here. So we have the artery, and that little triangle of perforators is supplying that fat pad. But also, you can see that every chin has the same hypervascularity. You have an oval shape, and you have this little line going up to the lower lip, and you can see that back if you look in body donors. It reflects the perforators. It is not your problem area. Here again, every lower lip has the same pattern. There we go. Every nasolabial fold may go up to the forehead, has the same pattern. Every nose, lateral on the nose, same pattern. It's getting a little bit boring. Forehead, same pattern. Different, same pattern. So you can download this publication on our website. It's for free, cutaneous.nl. You can use this as a preference. Are you looking at a bruise, or are you looking at these very specific skin patterns reflecting the perforators as good neighbors trying to help? Thank you.